Hello and welcome to ID Talk, Answers from Infectious Disease Experts. I'm Dr. Nathan Price, a pediatric infectious diseases specialist at Banner University Medical Center, Tucson, and associate professor of pediatrics at the University of Arizona College of Medicine. With Dr. Scott Olson, I'm the Arizona AAP Infectious Disease and Immunization Co-Medical Director. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thank you for tuning in today. This is the week of November 4th. So let's get to the questions. The first question is, we have seen many patients with persistent coughs lasting 1 to 3 months and have noted many positive nasal swabs for pertussis over the past year. Can you comment on the possibility of a false positive pertussis swab, or perhaps any cross-reactivity for other infections? Are other pediatricians in Arizona noting this trend as well? Great question. As we have kind of come out of COVID over the last couple of years, we're starting to see things resurge now that we're not social distancing anymore, and pertussis is one of those. I recommend that if you want to look more at the epidemiology of pertussis, that you listen to Dr. Olson's last podcast. So let's talk pertussis a little bit. Pertussis has 3 stages: the catarrhal phase, the paroxysmal phase, and the convalescent phase. Each of these phases tend to last a couple of weeks, but some of them can linger longer than others. The symptoms can be pretty severe, but eventually people tend to have a complete recovery, but sometimes they can have complications depending on the situation. The cough that people get can last for weeks and sometimes last for months. Colloquially, it has been known as the 100 days cough, so it's not surprising that some people can have coughs that last a long time. It's important to remember, though, that there's lots of other causes of cough out there, so things could be misconstrued as pertussis that might be something else. The other thing is when it comes to the cough and pertussis, we don't exactly know what causes or potentiates the cough. At first, people thought maybe it was toxin related, but there's more data out there to suggest that may not be the case. There are other things, though, that could come into play, such as different inflammatory markers, and some of the studies out there suggest that maybe bradykinin can exacerbate and potentiate cough. And so there are situations where people had pertussis, then had increased bradykinin, and then when they got other viral infections, they had a more severe reaction to that virus than they otherwise would have thought to have had. It can be that someone has a lingering cough because pertussis is just lingering, or it could be that something new has come and set up shop and caused that cough to be more severe than you would have expected it because pertussis had been there in the first place. So let's talk diagnostics. There's lots of options out there. You have serology, which can be complicated by someone's prior immunization status. You have culture, which people don't tend to do anymore. You have the DFA, which has fallen out of favor because it isn't very good as far as sensitivity and specificity goes. And then, of course, you have PCR, and that's what most people use. This is a good test, but like anything, it's not perfect. And this is because it can have cross-reactivity with other Bordetella species, which may not cause pertussis disease. When folks have looked at it in studies, comparing it to things like serology and culture and actual confirmed disease, it tends to have a specificity of 88 to 98%. The other thing is like a lot of things, is it can stay positive for a long period of time. And there was one study that was done out of Utah that showed that it took 205 days for one patient's PCR to finally revert to negative. So you can see that a positive test doesn't necessarily mean that you have pertussis now, or hard to know when a pertussis infection happened, and it could be that it was actually detecting a non-pertussis Bordetella species. So the other part of the question is are other pediatricians in Arizona noticing this trend as well? Well, I'm not on the front lines like a lot of you are, and so I haven't personally seen this happen, but it doesn't mean that it's not. And again, knowing how this test works, that it can have false positives and that it can also stay positive for a while, and the fact that pertussis has made a resurgence in the post-COVID years, it wouldn't be surprising to me that people may be seeing increased positivity out there. So let's move on to the next question. What supplies should parents have at home in case of very minor injuries, like cuts, scrapes, and burns, to prevent infections? What's recommended to clean the wound and dress it at home? There was a rather recent finding that hydrogen peroxide and alcohol can actually delay the healing process. So another great question. Like a lot of things in medicine, things change over time. And that may be because of different logic, different theories, sometimes different evidence. When it comes to wounds at home, one of the major tenets of wound care is cleaning it. And so, of course, cleaning still makes sense. People argue over the different methods of what to do. And again, it may be based off of experience, it may be based off of theory, it may be based off of evidence. Should you use soap? Should you use water? Should you use tap water? Should you use sterile water? Should you use an antiseptic like hydrogen peroxide or alcohol or something else? And again, people still argue over the details here, but long story short, we should be cleaning out these wounds, because as we're doing that, we're removing the particulate matter that could potentially introduce infection. So when looking at experience and some of the evidence, water is probably the best way to do it. And tap water is probably just as good as sterile water, as long as it's, good clean tap water. And, people discuss how long you have to do it, but long story short, you should be doing it enough to try to get the dirt out of there and try to wash out any of the potential infectious organisms in there. Soap should be okay, but most people recommend not getting soap into the wound itself, because that certainly could cause irritation and can cause problems. When people talk about using soap on a wound, they're talking about cleansing the skin on the external surface and not actually in the wound itself. And then what about the antiseptics? You have things like hydrogen peroxide that a lot of us have had it in our medicine cabinet for years and probably still have it. Well, there's data out there to suggest that hydrogen peroxide can actually be cytotoxic, and so it can delay and hinder wound healing. So most experts these days recommend against using hydrogen peroxide in wound care. What about these other things like alcohol, povidone, iodine, and that sort of thing? It's hard to say. People don't really know. There's some suggestions in the literature out there that things like povidone, iodine might be helpful in certain situations, but for the most part, for the wounds at home, it's probably unnecessary. So what about dressing or covering the wound? The current theory is just that a moist wound bed actually is better for healing than, say, a dry one. And so there's some evidence out there to support this. But you also want to make sure that you don't go too far and cause the wound to be overly moist and macerated, because then that can hinder wound healing as well. So some people will recommend things like occlusive barriers, using things like antibiotic ointment, say petroleum jelly. There's actually some studies out there to suggest that petroleum jelly is just as good as an antibiotic ointment. And so a lot of experts don't recommend using an antibiotic ointment. And that's because the antibiotic is often not necessary. Use of it could lead to resistance. And some people have allergic reactions to the antibiotic ointment that could make things worse as far as wound healing goes. Of course, keeping the wound clean should be helpful. And so some wounds may benefit from having a clean, dry dressing on top of it. Of course, you want to pay attention to that dressing and change it as needed in order to continue to make sure that the wound isn't getting dirty, which would then introduce the potential for more infection. And as always, we want to make sure people are up to date on tetanus. Now, of course, most minor wounds at home are not going to be tetanus prone, but some of them certainly can be severe enough to introduce anaerobic conditions, which would make someone prone to have tetanus. And of course, it's always a good idea to review if someone is up to date, and should they be brought up to date if they're not. So in my first aid kit at home, I would keep some petroleum jelly, I would keep some clean dressings, and of course, if someone gets injured, I would wash out the wound with clean tap water. Okay, so let's look at the next question. What population of children are recommended to receive 2 influenza doses, and how long does the child need to wait in between doses? Again, another good question. So for a more in-depth review on the influenza epidemiology and vaccine types and vaccine efficacy, I would refer you to our first podcast for this season. But this question certainly wasn't addressed in that one. When it comes to influenza vaccine, the first time someone in the age range of 6 months to 8 years gets vaccinated, they need 2 doses. And that's because the studies showed that age range, if they got a single dose, they didn't respond as well immunologically compared to those who got 2 doses. So if a child of 6 months of age to 8 years of age shows up, and it's the first time they're getting vaccinated, they need those 2 doses spaced 4 weeks apart. The AAP each year puts out a really nice guideline document that discusses what's recommended for influenza vaccination. And in that document is a really nice algorithm that makes it really helpful to sort out. But long story short, again, you need those 2 doses. And when trying to sort out, where you are in that situation, they refer to it as lifetime doses. So if you've had 2 lifetime doses and you're in that age range, then you just need a single dose for this season. If you haven't had those 2 lifetime doses, then this season you should get 2 doses and then move on. Again, the algorithm is really helpful for sorting it out. They also mention that if a child is 8 and needs that second dose but turns 9 in between during that season, you give the second dose. So let's go over a couple of examples. So let's say an 8-year-old shows up in your clinic and last year got a single dose of influenza vaccine, but before that had never gotten an influenza vaccine. So here we are in the new season. This child has not had 2 lifetime doses. So therefore, this season would need 2 doses, 1 now and 1 4 weeks later. And let's say when the child shows up 4 weeks later, the child has now turned 9, because it was during that same season, you still give that second dose of influenza vaccine. Next year, the child will be 9 and just needs a single dose. Plus, the child has already had those 2 doses that we gave this last year anyway. What about a 5-year-old that comes in that, say, 3 seasons ago got a single dose, didn't show up for the second dose? The next season shows up again, gets a single dose, doesn't show up for the second dose. So now is showing up into your clinic. That child has had 2 lifetime doses, so now only needs a single dose to be up to date, and from then on out, we'll just get 1 dose each year per the algorithm. So the key there is that 2 lifetime doses. If you are in the age range and you haven't gotten the 2 lifetime doses, you get 2 doses in the current season, and then from then on out, you just need a single dose each year. Again, I highly recommend that you look at that algorithm because you're right, it could be confusing. There's lots of nuances here. All right, last question. Do air purifiers at home remove airborne contaminants, including viruses? And is a built-in UV light recommended? Based on your knowledge, what is the best purifier to recommend to parents? Well, another really good question, and I'll be honest, I didn't know a lot about air purifiers until I got this question, so I've been doing a lot of reading. But I'll be honest, I don't think there is a right answer here because I don't think there's enough evidence to know one way or another. So let's talk about the air we breathe. There's lots of things in the air that can affect us. There's gases, there's particulate matter, and when it comes to particulate matter, we worry about things like viruses, vegetative bacteria, and fungi, as well as spores that could all potentially lead to infection. There are certain high-risk situations where these airborne infectious particles can cause major problems. For example, in bone marrow transplant units. These patients are at high risk for inhaling the spores in the air and getting infections with things like aspergillus. And so we use really robust filtration systems to try to decrease that. And there's evidence that if you do that, you can actually decrease aspergillus infections on the bone marrow transplant units. There was also a study done in the height of the COVID pandemic on a unit with lots of COVID patients that used a filtration system to try to decrease SARS-CoV virus in the air. And so they did the study where they looked at the air samples before and after introducing this system. And they noted that there were decreased amount of SARS-CoV-2 virus particles in the air. But we don't know if that would lead to decreased transmission or not. We also don't know if universal increased filtration in the hospital or universal use of filtration in the home would lead to decreased transmission in those settings. So with the available experience and data, there's logic to suggest that there could be some benefit to use in the home, but again, we just don't know. And we all know that there's lots of good logical theories that were disproven by a well-designed study. So let's talk filters a little bit more, and then you can decide what you may think would be best for you or for your patients. So the EPA has a nice document called Residential Air Cleaners, a technical summary, and I highly recommend that you read it if you want to learn more about filters, but it was really very interesting, very informative. So there are a lot of different things to consider when you're thinking about filtration of the air. The first thing is to know what is the volume of air that you need filtered and what's the situation you need to apply it to. So there's a lot of variables that come into play there. And there are certainly different options to use. Some systems are incorporated into the HVAC system. Some are standalone machines. Some will use passive systems, and some use a forced air system using a fan. The forced air fan type systems tend to be more efficient, but they also tend to be noisier. Some systems use a fibrous media filtration system. This is like our AC units at home where you have to remove that physical barrier and replace it from time to time. Some systems use electronic systems in order to apply a charge to the particles so they settle out of the air in various situations. So the fibrous filter system have different sizes of particles that can be excluded. And so you have to pay attention to that to see what size of particle you need to have excluded in order to have the protection that you want. So the industry has different measures that they use to help determine what may or may not be effective for certain situations. For example, there's the Clean Air Delivery Rate, or CADR, and this measures the amount of contaminant-free air that's delivered by the system, and it's reported in a cubic feet per minute system. Minimum Efficiency Reporting Value, or MERV, is used to estimate how well particles are removed. So the EPA states that your regular home HVAC system filters tend to have an MERV of 8. They suggest that if you want to try to filter out particle sizes, say for SARS-CoV-2 virus, you should be using a filter that's MERV 13 or higher. Another important thing to note is that some of the electronic systems produce ozone, and so you have to pay attention to that because ozone can be a lung irritant, and none of the ozone-producing systems are recommended for home use. So let's talk about the second part of the question about UV light. So UV light can certainly kill viruses and vegetative bacteria and fungi, but it doesn't tend to kill spores. Those are resistant to UV light and a lot of other things. So the efficacy of UV light really depends on the dose and the exposure time. And the problem with the home systems is they probably don't have a high enough intensity of UV light for a long enough amount of time in order to be effective by themselves. So the EPA doesn't recommend using a UV system if it's a standalone system. You certainly can get UV light incorporated into other systems, other filtration type systems. So if you're going to consider using UV light in your system, it really should be used in conjunction with either an electronic or a fibrous media filtration system. The other thing to consider about UV light is that some of the UV light machines have bulbs that aren't coated, and that can cause ozone as well. And so you need to pay attention to that as well, like I mentioned. And of course, with anything, cost is a consideration. You have to consider the cost of the equipment and the installation, and you also have to consider the energy costs as well as you're using these systems over time. As far as studies and data go with home filtration systems, there is some data to suggest that there's a modest benefit to allergy and asthma symptoms if you're using these home filtration systems. But like I mentioned before, there aren't any studies to support the use in home to prevent transmission of infection. Doesn't mean that it can't happen. We just don't have data to prove that at this point in time. So long story short, a home filtration system may be beneficial. It may decrease infectious material in the air, which could then decrease transmission of infection. And so you can consider, is it right for you? So based off of all that, I don't have a specific recommendation when it comes to should you use a filter or what filter type you should use. So if I were to put something in my own home, I would look for something that would cover the area that needs to be protected, that had a high MERV rating, 13 or above, that had a high CADR, that used UV light, that didn't produce ozone, that had a low cost to buy, and had a low cost to maintain. I'm not sure if there's any system out there that checks all of those boxes. So like anything, there may be compromises that need to be made. Well, that about does it for this episode of ID Talk. Thanks again for listening. Arizona AAP members can submit questions for future episodes to id@azaap.org. Arizona AAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, please visit azaap.org. Thanks again for all that you do. We'll see you next time at the next ID Talk podcast.